السلام عليكم ورحمة الله وبركاته. Thank you very much. بسم الله الرحمن الرحيم والصلاة والسلام على سيد المرسلين. So, Allah يعينكم, you're going to listen to an orthopedic surgeon talk. Please, hang in there. Can I have my talk up, please? So, كنت في مؤتمر في القصيم أمس, and we were talking about diabetic feet. And I love being in a conference with multidisciplinary people. In fact, one of our important team members is the physiotherapy. I encourage you to go and see their booth. في حتة العرض. Physical therapy is something that helps our patients a lot, and we all work together. So I'm going to start with this x-ray. This is what a knee x-ray should look like before the surgeon does his total knee replacement. And you can see that there is a reduction in the joint space. There are osteophytes if you look on the medial and lateral side, and this is a pretty good total knee to do. بس للأسف الشديد عندنا في السعودية and in the Middle East, I'm sure في مصر وفي الهند وفي أماكن كتير حوالينا, people come like this. They already have quite a significant deformity. تمام? They already have bone loss. And rheumatoid patients are more likely to look like this. They may have osteopenia or osteoporosis. They may have distortion of the anatomy. They have more likelihood of having genu valgus. And we know that all of these lead to a much more complicated surgery and potentially worse outcomes. And you can have complete destruction of the joint. So I hope by the end of this talk, we can all agree in this room that rheumatologists have done a great job in reducing the burden of the disease. With milder form of the disease, we have simpler surgeries, less surgeries, and hopefully better outcomes. I hope that also by the end of this talk, you'll be able to clearly articulate the danger of delaying surgery when it has been indicated, and list general risks of lower limb arthroplasty, and specifically compare osteoarthritis with rheumatoid arthritis after these surgeries. So bismillah, let's go. So thank you, rheumatology. The natural history of rheumatoid arthritis has changed. And how has it changed? I remember being an intern, and early in my residency, every orthopedic list in the operating room had a rheumatoid patient. يعني كنا نسوي radial head excisions, it's like having breakfast every day. كل يوم بنسويها. Alhamdulillah, now we don't see this. We really don't. And why is this? It's been demonstrated, I think, very well in the literature, like you've been saying in the past few days, وزي ما قلنا اليوم الصبح, إنه we have milder disease with less symptoms, less deformities, and less radiographic changes. And these improvements have largely been due to disease-modifying agents, but also due to the natural history. So there are many reasons, but we know this is a fact. Right. One of the nice studies I like to look at, عشان I'm a visual person, is this Kaplan-Meier survival curve. And it shows that there is a 1-year delay in the onset of osteoarthritis or joint destruction in patients who received a single dose of rituximab versus a placebo group. Now, I'm sure you have much better studies, but I just love this one because it shows in the blue is that 1-year delay in that onset of arthritic involvement. وكل سنة تفرق when we're talking about joint replacements. This is a 55% reduction in involvement with treatment, just with this drug. So when there is a reduction in joint destruction, then there is a reduction in surgery. منطقي جدا, صح ولا لا? Yeah. So we said early this morning, Dr. Maysoon, she said something right, that unfortunately rheumatoid arthritis patients are still having total knee replacements. بس شوفوا الفرق. When we look at all-time increase in total knee replacements done, it has increased by 20 folds, 20 ضعف between 1980 and 2010. Unbelievable, قد إيش much more total knee replacements we're doing. But when you isolate rheumatoid patients, actually the number has not increased. That's amazing. It's actually in some places it's been decreasing. So this has been echoed in the Finnish registry, where there's less rheumatoid patients undergoing total knee arthroplasty, and also in the Swedish registry, where there's a 24% reduction in rheumatoid admissions for lower limb surgery between 1987 and 1996, and then after that an 8% reduction until 2001. In the United States, the joint registries in Minnesota have shown that rheumatoid patients undergoing surgery within 10 years of diagnosis has been reduced from 27% to 19% in 2007. So great job. Please, صفق عليكم كلكم, please. Really excellent job, alhamdulillah. Now, I love to do surgery, okay, but I have enough, alhamdulillah. I don't want rheumatoid patients to have surgery. So great job, thank you. It's also been shown that the proportion of total knee replacements was, when you take all total knee replacements, 21% were in rheumatoid patients before 2000. And then after 2000, they're only 3%. Amazing job. Sarah, alhamdulillah, this is really good news for rheumatoid patients. So all of this has led to changes in the trends in the utilization of total joint and total hip and total knee replacements, and potentially better outcomes. Tamam? So let's talk about the benefits, and then let's talk about the risks. Survivorship is one way orthopedic surgeons, زمان كنا ننبسط نشوف الإكس-ray, 20 years of a total knee in a patient. Good job, Husam. I did a great job. Well, this is one way, but we're going to talk about other ways. So how long do these hip replacements last in patients? They last a long time, alhamdulillah. So a recent study just recently published 2 years ago, looking at the National Registry of England, and they did 665, almost 1,000 total hip replacements, and they followed them up. And at 14 years, 96% of those hips were still in there. So بمعنى آخر, they only needed to revise 4%. And when you look at patients who had surgeries in high-performing centers, high-volume centers, the risk was even less. So the survivorship was 97 to 98%. And those revisions were usually for infections or trauma, things that we cannot really control a lot once the hip is inside. How about total knee replacements? So this is not rheumatoid patients. We're talking about osteoarthritic patients, and we're looking at them in the young adults under 55 who are at high risk really for revision. ليه? Because a 55-year-old, you're going to utilize your total knee much more. And they looked at patients under 55, they followed them up, and the Kaplan-Meier survivorship was between 90 and 98% at 5 to 10 years, and between 84 and 99% up to 20 years. That's really excellent. Tamam? And the reason for revision was polyethylene wear, loosening of the component, and infection really is the biggest one, as you will see as I go along. So survivorship is not everything, right? The patient can have a total knee for 20 years, بس قاعد 15 سنة يعرج وما هو مبسوط, right? So you cannot just say survivorship. We want to know what their functional outcomes are. So functional outcomes in the same study for young adults showed that the Knee Society functional score was really good at 5 to 10 years and continued to be excellent up until 25 years. So these people have good functional outcome scores. And this is reflected also in the WOMAC and the Tanger scores. So this is osteoarthritis. This is our baseline. We're going to compare the rheumatoid arthritis patients to these patients. So how well do the rheumatoid patients do? Alhamdulillah, they do pretty well. This study published in 2016 looked at 4,450 patients, of which 163 patients were rheumatoid. And this is from a registry also. It's a prospectively collected data. And they showed that the WOMAC pain and function index scores were significantly improved from pre-op to post-op, and multivariate regression analysis failed to show that rheumatoid was a factor or failed to show an association of rheumatoid arthritis with postoperative pain or postoperative function. In other words, both rheumatoid and osteoarthritic patients undergoing total knee replacement had similar excellent functional outcome scores. Alhamdulillah. Tamam? So far we said that these knees and hips last for a long time. They have excellent outcome scores. Still, this is not enough. Because if the patient is not satisfied, I'm not satisfied. So what is the satisfaction rate? Well, unfortunately, despite all of this, we still have, it's a range, but we still have up to 20% of patients who are not satisfied after total hip or total knee replacement. What's the major reasons? Well, the main reasons are loss of range of motion. وهذا أكبر مانع للناس في الدول الإسلامية والعربية إنهم يسووا العمليات هذه. You're like, I don't want to do a total knee because I don't want to lose motion, right? Yes, that's right. But we're going to address this in the next slide. So the other reason is pain. They continue to have some kind of pain. جدتي الله يديها العافية ما شاء الله. She's almost 90. Every time she sees me, عندي ألم. And it's nowhere around the knee. It's in the tibia, it's in the thigh, it's muscular pain, but they still continue to have some pain, and this is a concern for them. Finally, they still have some functional limitation. Tamam? So what to do about this? And if there's only one slide you can remember today, it's this one, please. This is a really good study. I encourage you to read it. As rheumatologists who counsel patients before surgery, I think this will help you help you counsel your patients. So this group tried to find predictors preoperatively of how well patients will do after surgery. And they specifically addressed range of motion, pain, and function. What did they find? They found that the single most important predictor of post-operative outcome was the same outcome before surgery. إيش يعني؟ يعني less preoperative range of motion means less post-operative range of motion. Less preoperative walking distance means less post-operative walking distance. More pain before surgery means more pain after surgery. Why is all this important? Because when we delay surgery, it's been indicated, but we keep on delaying it and delaying it and delaying it, patients will get less range of motion, less walking distance, more pain, and خلاص منطقيا and by evidence, they're not going to do as well after surgery. So please, if total joint replacement has been indicated, try not to delay it. Tamam. So now this is the excellent outcome we have. How about adverse events? Adverse events do happen, of course. And in this study, they looked at a national database looking at 90-day post-operative complications, revision rates, and readmissions. And they looked at inflammatory arthropathy in general, looking at rheumatoid, psoriatic, and ankylosing spondylitis, compared them with 1.7 million patients who had osteoarthritis, and they did their total knee replacements between 2005 and 2012. And what did they find? They found a higher incidence of complications, revisions, and readmissions in the inflammatory group. And within those diagnoses, there was no difference between them, so all of them had higher incidence of these complications. Now, the literature is mixed on this because other studies, this is a systematic review, that found no difference in 90-day complication or mortality and no increase in thromboembolic events after total knee replacement between rheumatoid and non-rheumatoid patients. However, there are only 3 studies that explicitly looked at thromboembolic events. So maybe we really don't know if the incidence is indeed increased or not. But what is definitely clear in the literature, that total knee replacement in rheumatoid patients has a higher risk of infection, and total hip replacements in rheumatoid patients has a higher risk of dislocation. This is for sure. And a nice study that looked at infection risk was from the Finnish registry, and they did their Kaplan-Meier survival curves, and you can see the first line on the very top is patients who are osteoarthritic patients who had total knee, and their survivalship at 8 years, specifically looking for infection. And the reason for revision was infection. They had more than 99% survivorship, whereas rheumatoid, they had around 97.6%. This was significantly significant. However, the good news for rheumatologists that rheumatoid arthritis is not the biggest risk for infection after total knee. The biggest risk, you see the green line and the blue line, these are post-traumatic arthritis. So that is the biggest risk. Now, when we talk about revision total knee replacement, which is a much bigger surgery, a recent study looked at the national database in the United States. They included 132,000 revision total knee replacements, and they found, you all know this, that females tend to have more likelihood of complications, but the age group was similar between osteoarthritis and rheumatoid arthritis. and rheumatoid patients had surgery, more likely to have non-elective surgery. And this is big. We know في عالم الorthopedic anesthesia and surgery that the surgery electively done has less risk than the surgery done under emergency situation, and infection was the main reason. And this was clinically significant, statistically significant. So what is the difference? Patients who are rheumatoid were more likely to have postoperative anemia, requiring more likely to have transfusion. They were more likely to stay in the hospital longer, and therefore a higher cost of care after revision total knee replacement. Rheumatoid, for whatever reason, where you will tell me, they were less likely to have UTIs and less likely to have acute renal failure, but other morbidities and mortality was the same between both groups. So to conclude here, I want to thank you all for the great job you do for our patients. We have milder disease leading to less rheumatoid patients requiring surgery. Rheumatoid patients are having their total joint replacements at an older age. Inshallah, this means that they will continue to have it for longer and require less reoperations. Clinical pathways and multidisciplinary approaches. لا تنسوا physical therapists, روحوا زوروهم. They have a great role in helping our patients, and I think this is why we're seeing less morbidities overall. It's because of this multidisciplinary approach. We do know that total knee replacements have higher infection rate, and total hip replacements have a higher dislocation rate. And please remember that the delay in total joint replacement in lower limb, even in the upper limb, if it's already indicated, and I don't want you to send patients before it's indicated, but if it's indicated, delaying it actually hurts your patients. Thank you very much.